Chapter 2, the Adherence Needs Assessment. This is Tom McKeithen with Healthcare Performance Consulting, and I will be discussing the multi-component needs assessment that was done around adherence. This needs assessment study took place from January through December of 2008 under a grant from Pfizer Corporation, and it consisted of several components. There was a detailed literature analysis. There was a meta-analysis of the literature. There was horizontal and vertical interviews done one-on-one with physicians, and I'll explain those a little bit later. A change readiness inventory survey. We looked at some of the existing models for adherence and actually developed new models that will be discussed later, and derived implications for continuing medical education and specifically a core curriculum for continuing medical education. Now, this needs assessment focused on 3 chronic disease areas because we know that adherence is a much greater problem with chronic disease than it is with acute medical disorders. So for the purposes of this study, we focused on 3 specific areas, and those were diabetes, hypertension, and asthma. And the reason being is that obviously these are all high prevalence, high cost areas of medicine, and we felt like the biggest bang for the buck would be in these 3 areas. So in the literature search and the meta-analysis, we found several things. We found that most intervention studies for adherence were actually implemented by ancillary healthcare providers. In other words, it wasn't the physicians necessarily involved in adherence projects. It was the nurse, the case manager, the pharmacist, the healthcare plan, so on and so forth. Also, there's evidence that does not indicate that current interventions are effective in a significant way in improving adherence for chronic conditions. So there's a lot of room for improvement there. However, we did find some commonalities of successful adherence interventions. We found that ongoing interventions are more effective than so-called one-shot interventions, and that the best interventions are intensive, they are personalized to the patient, there's frequent monitoring involved, and patient education involved in the most successful adherence interventions. Now, in the next slide, adherence from the physician's perspective. This information was derived from personalized one-on-one interviews with physicians. And these interviews took on 2 different flavors, if you will. First was horizontal interviews, which were done with a cross-section of physicians dealing with these 3 clinical areas from across the country. These interviews were primarily done by telephone and lasted 45 to 60 minutes. There was also a set of vertical interviews that were done within a single healthcare system, the University of Virginia healthcare system. And the reason we did a sampling of these interviews from one system was to determine what is the role of healthcare systems with respect to adherence, and what are some of the things that they do to improve adherence. What are some of the interventions, and what are some of the system barriers that may exist? So we found out a number of things from these interviews. One is that physicians know that adherence is an issue, but they don't necessarily take on any personal responsibility for adherence. They tend to place that responsibility on the patient. They tend to think that if the patient understands the instructions, then they should be able to comply. But we know from this study and from the literature that there are many other factors involved with patient adherence. We did find that there are a number of system barriers that exist. Oftentimes, one of the biggest barriers is getting information from the patient from one part of the system or one piece of the system to another piece. For example, a primary care doctor that sees a patient that recently visited the emergency room, but that primary care doctor has no access to the tests that were done in the emergency room, and so doesn't have that data available to help. So an example of a system barrier that may exist and prevent adherence. Another finding was that physicians do not typically make any assessment of adherence before they treat the patient. In other words, when they are evaluating a patient from a clinical standpoint, there's really no evaluation that's done to, at least consciously, to assess this patient's ability to adhere to some treatment regimen. So that's a general statement. It certainly doesn't apply to all physicians, but generally we can say that some sort of adherence assessment is not done before the patient is treated. Conversely, when treatment fails with a particular patient, physicians often do not take adherence as being a possible source of that failure. What they tend to do is look at the medication or the treatment and say, what is it about that treatment that did not work for this particular patient, bypassing any consideration of patient adherence to the treatment. We also found that there are few resources or systems available to improve adherence. Now, nearly any physician will tell you that one of the things that they do to increase adherence is to use medications, for example, that are only given once a day as opposed to 2 or 3 or 4 times a day. And that's all well and good as far as it goes, but there's no support for that. There are certainly those medications that have to be taken more than once a day, and but that's typically where the physician involvement with adherence ends. And so there are a few other resources or systems in place that would help improve the adherence of that patient. We also found that communication is key, and that those doctors and those healthcare systems that have better communication ability and better systems in place to enhance communication are better able to increase adherence with their patients. We also found that physicians spend more time discussing the purpose of a medication or a therapy, the timing or the dosing of the medication or therapy, and the side effects. That's essentially where they spend time discussing a treatment with the patient. They tend to spend less time discussing the consequences of non-adherence to the patient, so they don't give the flip side of it. They tell the patient why they should take the medication, but they don't tell them what happens if they don't take the medication, and that's an important component. They also don't typically discuss interactions if the medication is taken inappropriately as being one of the possible consequences of that lack of adherence. And they don't talk much with patients about refilling their prescriptions in a timely fashion and their ability to refill prescriptions. And as we said before, non-adherence is much more of an issue with chronic conditions than it is with acute conditions. And the one exception to that would be chronic pain, which there's typically very little problems of adherence with chronic pain. Some of the findings that came out of the change readiness inventory and the interviews was a look at some of the barriers that exist to patient adherence. And we know that there are a number of these, and they certainly all play a role. And the various categories of barriers are detailed to a much greater degree in the online report that is accessible. However, we'll take a look at some of the significant barriers in this chart, and what we see is that out of the 9 barriers that we had identified, there are about 4 to 5 of these that were considered to be somewhat significant. And you can see the first 4, reading from the left-hand side, are all over level 3. So on average, by the respondents to our survey, which were physicians, they considered these to be the most significant barriers. Now, one thing to remember as you look at this chart is that these are just average responses. Certainly you will have subgroups of physicians for which certain of these barriers are much greater than are represented on this chart. And so the key point there is to make sure that for any educational programs that you're doing, to the extent that you can, gather your own information about what barriers to adherence may exist with your target audience around that specific clinical area. So again, reading from the left on this chart, we found that lack of time was a big factor, and this coincides to a great degree with communication. Certainly if there is a lack of time for a physician to interact with a patient, they're not communicating, they're not emphasizing the importance of the interactions that we discussed earlier, the consequences of not taking a medication or complying with a therapy, and so forth. Physicians also perceive low health literacy of the patients to be a barrier to adherence. The fact that some patients simply don't understand either the instructions that are given or the implications of adhering to that or not adhering to that therapy. Formularies are perceived to be a significant barrier. And this goes along with the interview findings that we had, that one of the most common adherence measures, or one of the most common measures physicians take to improve adherence, is by prescribing medications that are once or twice a day, as opposed to those that are taken more times a day. And finally, the largest barrier that was perceived by these physicians was the cost of the medications themselves. And certainly there are resources out there in any clinical area to overcome that barrier. Physicians just need to be informed about these, or to have systems in place where they can overcome that medication cost barrier. And finally, the last one, the last barrier that was just slightly over the neutral line, which is the level 3, as conflicting instructions. In other words, the perception there is that some patients get conflicting instructions from, for example, a primary care physician and a specialist that they may see, or they may get conflicting instructions from their physician and the physician's nurse. So obviously, again, related to the communication issue, is very important in relieving this particular barrier to adherence.